popcorn this because I don't want to, you just call out, introduce yourself. And if you want to throw it in the chat, that's okay too. And when it slows down, we'll let it stop there. But I just would love to do this for 5 or 10 minutes. So take it away.
I'll say Carolyn Cleary. Thank you, Renee. Effervescent.
I love that word.
I'll go next. Kathleen Mania. Oh, sorry. From Grace Pediatric Medicine, I'll say empowering.
Doug Bennett, Irondequoit Pediatrics. I'm going to say available.
In the professional sense. Right?
Daryl Gagnon. Dedicated. Thanks, Renee, for everything.
Hey, Renee, it's Tobe. I just want to say, how about indomitable?
Joanne Cordaro, amazing superhero. Sorry, that's 2 words, but
They fit together perfectly. Go for it. Go for it. I'm gonna read the ones that are coming in the chat. Whoa, they're coming fast. Kate Sharma, my word is connected. Robin Shep, my word is consistent. Cindy Rand, organized. Willie, my word is supportive. Angela, my word is passionate. Kevin O'Gara, understanding. I don't know if I missed anybody in the chat there because they were sort of flying through pretty fast.
Does anybody know what indomitable means?
I love indomitable. Daryl, you unmuted.
Courageous.
Courageous. All right, team. I'm looking to see. I'm going to just say 2 words, 3 words. One of my heroes. Forever, forever grateful, Renee. So thanks for participating. You could, and there's more: integrity, leader, collaborative. Oh, just keep them throwing in the chat there. Renee, I know that you don't like for things to be demonstrable. Renee is not a hugger, but I've turned her into one. I just want to say that's my accomplishment in life. I've turned Renee into.
Me too, LJ. Any chance I get.
We've turned her into a hugger. And we just wish you all the good things. You still are stuck with us for a little while here, kid, but we just wish you all the good things because you deserve them. So thank you for
so much. I really want to just say thanks. It's really made my night, made my week, my month for you to share those nice things about me. It's been the privilege of my life to work at AHP with you and with you all. And I have so many great memories of recruiting every one of your practices. I'm really grateful to you all for taking a chance on AHP. And I'm confident that, the organization, with leaders like with LJ and Jana, and Daryl and so many others remaining in the role at AHP, your interests will always be top of mind and top of heart at this organization. And I'll be always rooting you guys on. I love our AHP pediatricians, and you're just the nicest people who just do so many great things for our community. I mean, it's been a privilege to work with you all. Thank you.
I love you, and you can yell at me later because I put you on the spot at the beginning of the meeting and not at the end, but there was no other better introduction for the start of this meeting. So check the chat out when you can, but not too much right now because you're going to have to speak in a few minutes. So I don't want to totally throw you off. All right, so moving through our agenda, you're going to see we're going to be touching base about a number of different topics, kind of updating on some of the work that we're doing, some of the pilot work we've been doing. But I want to start the meeting with just a very candid and honest conversation about, the reality that all of you are facing. And I want to make sure that we acknowledge
That life sucks.
the difficult financial situation that we find ourselves in, and that particularly our primary care providers in independent practice, and most particularly pediatricians in independent practice find themselves in right now. And I think there's 3 things I want you to know in this space is that we will not give up from the AHP end, fighting for solutions and trying to broker solutions that will make a difference for you in your practice, for your practice teams, and for kids and families. That I am grateful for the transparency that so many of you have been willing to share with me, with our team. Many of you, we did a sampling survey of many of you to sort of assess the changes in practice, the increase in Medicaid, the impact of fee-for-service reimbursement that has not had any substantive increase for such a long time. The sort of stark contrast of the COVID pandemic and then the abrupt cessation of much of that reimbursement with the end of the state of emergency. And I think the impact of mental and behavioral health has really shifted all of the work that you do and is not being compensated for in a way that's sustainable. And I think that one of this group who is not on my front screen, may be on another screen, and shared with us, it's all about the math. The math doesn't add up, and it needs to start to add up. Things have to start to change in the equation for us to sustain the kind of pediatric community that we've been so privileged to experience in our region. So a couple of things. Some of this group have come on to a couple of calls with Excelis, some of the primary care providers, to personally share and very transparently about what it is like to practice right now and the difficulties that are being experienced. My husband, Jeff, who you all know, has a role, a volunteer role at the state, the Medicaid office, and was able to get this topic introduced very urgently to the director of state Medicaid and the leadership team there. And we just spoke with them again today, and they are listening, and they are concerned, and they are looking at ways to be able to actually change the reimbursement structure in Medicaid, but that's not going to happen tomorrow. But it is something they're looking at with more urgency that hopefully we'll see some revision within the next 6 months. There's nothing that's definitive yet. We still have ongoing conversations with Excelis, but there are ongoing conversations, and we're waiting for feedback and response in meaningful ways. And I guess I'll just say again, like, as much as you feel comfortable with us at AHP, with me and my role, and can share where you're at, not on this call, I'm not going to do that in a public forum that's being recorded, but if you're willing to reach and talk with us, that really helps to be able to share real stories and also share the sense of urgency. This is not just something of the future, but this is something that has been evolving for a while, but I think has become more of a imminent reality for some of our practices and well, for many of you. So that was a long way of saying, as we talk tonight about gain share, and we talk about comprehensive developmental screening, and we talk about our Med user group and the things we're working on that we hope will improve your ability to deliver care, we recognize that they're all important things, and we're not going to stop doing those, but we are going to focus on the biggest issue that is what's driving everything for you all. So again, I appreciate very much that you've been honest and been able to share, and would just ask for as much more data as you're willing to give to us. And as we can, we will open up more and more opportunities for conversation with the insurers and with state Medicaid. So not enough specificity. I would love to have been able to say there's a whole plan to roll out tonight, but I actually have hope because people who have the power to make change are listening, and I'm listening with like ears wide open. And we're hearing that from staff from within state Medicaid and some of the staff within Excelis. So thank you for that. That's my speech for the night. So, and I'm going to turn it over now to the agenda. of our meeting, unless anybody wants to make any comments about that. I'll just leave you space for a moment, not asking you to have to, but if you'd like to, please do. Okay, I'm going to turn things over to Kevin Kelly. Kevin has a couple of topics he's going to talk with you about: comprehensive developmental screening rollout, and then also some brief highlights about the reproductive health counseling and LARC placement training that we're providing. Go ahead, Kevin.
Thanks, LJ. Good evening. Hope everyone's getting back in the swing of fall, you know, getting kids back on the bus and watching the Bills lose in horrific fashion. I had to get that in there. Still hurting from that. I'll share my screen. So, comprehensive developmental screening pilot with the Mendon pediatric team. It's been really great. I just want to share some updates with you guys. The agenda we'll go over is the pilot overview, status and resources, and then timeline for scaling to the network. So we'll dive right in. AHP promotes evidence-based approaches to comprehensive developmental screening, and that's why we purchased the Bright Futures Toolkit. That toolkit offers pre-visit questionnaires, visit documentation forms, and patient or parent handouts. As you can see, the Bright Futures Guidelines recommends ages 9, 18, and 30 months for screening for global developmental delay, and ages 18 and 24 months for autism spectrum disorder screening. On this screen, you can also see the New York State Medicaid coverage, which, you know, LJ kind of alluded to earlier. We'll get into that a little bit later on, but you can see the screening tools validated right here. It's the ASQ3, the PEDS, the SWIC, the POSI, which is for autism, as well as the MCHAT. We'll get into the billing a little bit in the next slide, actually. Any questions so far? So Kate, the nurse manager at Mendon Pediatrics, really spearheaded the Meta implementation. She was able to edit existing reports and really optimize and collaborate with the Meta support team. So she really spearheaded it and really took the ball and ran with it. But we were able to kind of, the biggest success was definitely the pre-visit planning. We switched sending out to parents from 1 week to 2 days out, and that really helped out. Compliance was way up, no more chasing, and the workflow was much easier. So that was a huge success there. Just a minor adjustment, but it went a long way. The SWIC integration, we're currently, still working on auto scoring capabilities and thresholds for a quicker referral and follow-up, just really trying to optimize that and really get this screening done as efficiently as possible. And along that same vein, the SWIC integration, as far as the Mendon team, they thought taking out the POSI, the SWIC autism screen, which is integrated in the SWIC, they opted out of that and was able to hide that portion of the screening and just in favor of their MCHAT. So they just prefer that workflow a little bit better. And then billing and coding, I know we don't really have any specifics like LJ alluded to earlier, but New York State payers are removing many screens from the 2023 fee schedule. So we're exploring that further, and LJ has our back. So we'll get back to you as soon as possible. LJ, I know you already touched on it, so I won't kick the ball over to you right here. And then we did develop a billing and coding specific resource though, so we'll get into that, and it is available when we do scale out to the network. As far as the other resources, huge thanks to Nikki Spring. She put together, actually on the next slide, it just lists everything, so we can, on the last slide, I'll get into that. But as far as the external resources available, the Bright Futures, I just want to continue to spread the word for the institutional login. And please feel free to reach out at any time, and I'll hook you up with those credentials. Just still trying to spread the word. And then the CDC free milestone tracker, which patients really like, the parents really like, as everyone's moving towards their mobile, and really like to track those milestones. So that's been a huge hit with the parents at Mendon Pediatrics. And then the AHP resources that Nikki helped put together, as well as LJ and a few others. patient handouts, monitoring resources, sensory processing, referral step-by-step process, early intervention referral template, and billing. Like I said, so we actually wanted to make this available in QR code as well. We can print them out, but Mendon's team felt that the workflow was a little bit overwhelming, and especially when certain parents, would take the handouts and literally throw out the handouts in the office or in the practice. And we are trying to discourage that. So we want to offer that in a QR code, which also makes the workflow easier as each patient comes in and out of the room. The staff can just put in a index card with a QR code and just have the patients or parents scan that and have that if they want it down the road. It's on their phone forever once they scan it. So they can't just throw it out in the office. So that was a little discouraging, but we came up with a solution. Any questions so far?
Hey, Kevin, if there's not any questions right off the bat, I had just a couple of comments to add. First of all, thank you so much for your work on this and your leadership in this space and for summarizing this. I think that I just wanted, before Kevin talks about the next steps, I just wanted to add that the decision to switch, the decision Mendon Pediatrics made to switch from the POSI to the MCHAT was also very much supported by a consultation we had with our developmental behavioral pediatrics team. And so, one of the things is we're looking at various tools. We're trying to connect with all the experts that we have available to us. And so working very closely with developmental behavioral peds to look at this and to also begin to think about, we recognize that the difficulty with all of our screenings are, can we refer? And what's the wait time for referral? And so we're having some preliminary conversations with DBP, as well as with the Grow Rochester team to think about ways to enhance resources for referral and streamline pathways. So I have to ask you to stay tuned on that, but we are working in that space. And wanted to thank, again, the Mendon Peds team for helping us with that. I'll let you talk about next steps, Kevin.
Thanks, LJ. Yeah, so we're just looking to get Mendon Peds screens, continue to get some more under their belt as they, provide general feedback and report building. We plan on lifting to other Mendon practices, partner with ECW to build out these tools, and then, build out reporting from our pop health vendor. And then we want to scale the network in the fall. I'll be reaching out to the practices. Hopefully you want to learn more and engage. So looking forward to that. And I appreciate your time. And if there's any questions, feel free to reach out or chime in right now.
Hi, Kevin. I can turn on my video. I was just eating, so I didn't want you guys to see. I have a question. I really want to start using this WIC in our practice. I'm just really nervous about the lift that it's going to be to integrate it into Meden and like previously created templates and care plans. Did you guys, if you guys use Meden or if anyone else uses Meden and integrated this WIC, was it relatively easy, or is it going to be like a couple of weeks of a project for us?
Kevin or Jen, I don't want to put Jen on the spot, but I see you're on there. You're smiling. So
I'm here.
there you go.
We actually, we do have a template integrated in Medent. We sort of changed it a little bit. So I don't know what our template now looks like compared to the original Medent that they have on file, but we can figure that out for you. And it's relatively easy to figure that out. We also can score it now. So it does automatic scoring for the questions and gives you a little, we switched it so it gives you a little framework because not everybody comes in at 9 months. Sometimes they're 10 months, sometimes they're 8 months, and the numbers on the milestone screening depend on what month the child is when they're being screened. But it's within that template too. But I'm sure we could get that to you easily, I would hope, right, Kev?
That would be awesome because I've just been scared to integrate it because I just don't have the time to do it right now. Like I keep putting it off.
We were really scared and we like held back for a long time because we wanted something that was electronic and able to be done before we were seeing patients in the office, because all of the developmental screening forms are quite cumbersome for a parent to be filling out while we're trying to get the baby ready and measured and weighed and everything else. So honestly, it has worked quite well for us. We have been sending it out about 48 hours prior. If the parent shows up and they have not filled it out, our front desk makes them fill it out on their phone before they even get back to the room. And then it gets pulled in. So I would say, gosh, on average right now, probably 98% of the time I have the SWIC in the chart before I even walk in the room, which is honestly due to my team and the fact that they're done just such a great job with integrating it and getting it out to parents before I see them. But it's not as hard as you think. It's not as hard as you think. And I would also say scoring and interpreting isn't as hard as you think. Like I remember when we first started doing MChats and just feeling really overwhelmed with the fact that we would be scoring this thing and how do we interpret it. And I feel like the SWIC is a little easier. Like within a couple of weeks, she'll be dealing with it pretty easily.
Fabulous. And then does that take the place of your pre-visit questionnaire? Are you just substituting it or in addition?
Yeah, we don't typically do pre-visit questionnaires for our babies. We do for our older kids. So it has taken the place because we weren't necessarily doing pre-visit questionnaires with our 9-month-olds, 30-month-olds, and 18-month-olds. Yeah, so it does.
Thank you.
I guess. It has a lot of good screenings on there, including domestic violence and food insecurity. So it's not just a development screening. It has other things at the bottom. A lot of the things that we want to screen for, it has at the bottom too.
Thank you so much, Dr.
I'm
Leslie.
happy. This is lovely. Thank you. And of course, like, you know, we promised Jen we wouldn't make her talk, and then we made her talk, which happens every time we bring this up.
That was my fault.
But one of the things that we have tried to put together is kind of like an FAQ best practice. So Karina, if it would be helpful, I would be happy to make you my test case. We can share that with you, see if it answers some of the questions. If not, happy to create a little bit more documentation, because I know not everyone has a chance to engage quite in this way. As Kevin mentioned, we are looking to roll this out to anyone who's interested in the fall. I think we've got some nice workflows. And when it comes to the MEDEN templates and documentation, just to put more people on the spot, Willie is going to be a great partner in that space, making sure that you get a chance to take a look at what's in MEDEN and also what we listed for men in pediatrics, because I think there's some utility in pulling forward the work that's already been done. So I really, really appreciate the whole team at Men in Pediatrics has been absolutely wonderful in partnering on this. It's been really exciting to see it lifted.
Thanks, Elizabeth. You guys have been great too, though. I will say, walking through every step of the way.
Thanks, Jen. Thanks, Elizabeth. Thanks, Kevin. I want to add one comment before you go on to your next topic, Kevin. This is so, so important. And I know that developmental screening and comprehensive screening is just part of what we do in pediatrics, but in many, many instances, we rely on our sense that we can look at a child and tell how they're doing. And, you know, you can do that for a certain amount of time, but there are these key intervals where we need to use some type of evidence-based screener. It really is important. And we know from the pandemic, I will just share with you that the screenings, this is unique to the city of Rochester, but these are some of our kids who have experienced the most isolation, the most loss of school or any kind of childcare or young, you know, early pre-K education. But we are seeing kids who more than 50% of children are screening with at least one or more significant developmental delay, more than 50%. And so that's not that percentage is higher than it may be in other districts and in other areas, but this will be true for kids from all of our communities, in all of our practices. So I really appreciate the AHP team in working on this and in giving tools and workflows that make it doable and integrated into the record. So thanks, guys. I think it's really critical. Appreciate y'all.
Thanks, LJ. Lark placement training. We actually have an in-person training at Corporate Woods next month. So Nexplanon placement training. Some of you have already had direct correspondence with Connor at Nexplanon. So there is a cap on the number of attendees. They have 13 per trainer, and there were 7 that have already shown interest with Connor directly. So unfortunately, there's only 6 spots left, but I wanted everyone to be aware. And then based on how much how many people reach out to me interested, we can hopefully set up another training, but I just want to let everyone know. I'll put my email in the chat here. Whoever's interested in placement training at Corporate Woods, it's October 12th at 5:30 to 7:30. And that's a Thursday. So I'll put my email in the chat now, and please feel free to reach out, and hopefully we can get you in there.
And
Thanks,
Kevin,
LJ.
I wanted to add one thing in terms of reproductive health counseling and LARC. Many of you know that sort of the focus of LARC in the provider engagement report is not that you all be placing Nexplanon or other forms of long-acting reversible contraception in your office. It really is to sort of up the game across our whole region for providers who care for teens and adults, so that we know that our patients are getting evidence-based and really patient-centered, non-coercive reproductive health counseling. So Rachel Phelps did 2 great lectures, same lecture, repeat performance, last year that were incredibly well received, but we also know that many of our teams were not able to attend. And so she is going to do, she's going to come back for a 3rd time with us. And we will send this information out in the minutes from this, or Jana's super cool minutes from this meeting. But that will be Thursday evening, November 9th from 5:30 to 6:45, just as it was done before, a 1-hour talk with a 15-minute open Q&A. If you weren't able to attend before, or others in your practice were not able to attend, I highly recommend it. Rachel has got to be one of the best clinical teachers I know, and she's funny. It's entertaining. You can eat your dinner while you listen. And we will be featuring that opportunity to learn from Rachel in addition to that session, but that's a big session that we're holding in November. And that's really what we're looking at for the provider engagement report, that people will give an hour, an extra 15 minutes for Q&A to learn and to bring that back into their clinical practice. If that encourages you to, as a practice, to desire to reduce barriers to LARC access and provide Nexplanon in your office with 1 or 2 providers, that's awesome, and we will support you in that. But that is from the provider engagement report's perspective. We're really looking at making sure we're educating all of our teens and young and adults in the best way that we can for this. That's what that's about. All right. Any questions on that one before we move on? All right. So moving on now, I'm turning it over to Sarah Dixon. Sarah's got 2 topics to cover for us: the Medent user group rollout, and then the patient-reported demographic data collection.
All right. Thanks, LJ. So yes, I have 2 topics for you tonight, some updates about things that are coming in the next few weeks. I'm just going to move you so I can see you all. So first is the Medent user group. We have the first topic ready and materials ready to be released, like I said, in the next few weeks. We've been, Elizabeth would probably say this, and the Medent user group has been talked about as an idea for a long time, as most, if not all of you know, and we wanted to, find a way to bring some useful information to practices and your teams without adding another meeting. So we've decided to start asynchronously. So these materials are going to be available on the AHP website. I'm going to give you a little preview of that. So based on the feedback from the survey that we did last year, and discussions with Medent and a couple of conversations and demos with providers, we landed on focusing on the authorized representative as the first topic. So I have, the cover page here of what we're calling our manual, and the authorized representative, as probably all of you know, is the capability that allows you to add another or give another user access to the patient portal that's not the patient. So as Meta, hopefully explores increasing the capability of the feature of the authorized representative feature and the patient portal, because we know it's pretty limited in the way the current form that it's in. We're hoping that reviewing and updating practice workflows to incorporate the authorized representative more regularly will be valuable to you and your teams. So what we've talked about with Medent is that activating the authorized representative feature can help ensure accurate documentation and logging of activities in the patient portal, and also support or begin to support patient privacy with the portal. So this is the cover page. I wanted to share briefly the table of contents of what we're calling the manual. It's a long, PDF document, but it's nice because you can click through it. So it's got background information about the materials, and but just more general information about the authorized representative, just so that everyone's on the same page with the feature and what the current status of it is, what's available to you. And then how to actually incorporate and activate the authorized representative for your patients. This is just an example of one of the pages, the fast facts, just to give you, again, some background information and basic information about the capability of it and in its current state, which again will hopefully be evolving over time to be more and more useful to you and your teams. Right now, the other thing I wanted to point out was that the email activation for authorized representative portal access is now available, or will be available once you move to the new version. So that's something that when you're ready to move to the new version and make that request to Medent, if you haven't done that already, that will be available to your teams. And there's information about how to do that and walk through that process in this manual. This last piece here is just giving an idea of what the materials are that will be available. So like I said, the manual kind of walks through everything, and you can click back and forth. There are a couple of videos available, the quick clips, which are, if you're familiar with the Medent video tutorials that they have on their website, where they just kind of quickly click through to show you the steps to click through something. So that's what we mean by video. And then the infographic kind of distills down information that's in the manual to make it more bite-sized and pull some of the most important information out. And then last that we're finalizing right now is the patient handouts. So we put together some documentation that is intended for, there's two forms, intended for the adolescent patient and intended for the parent of or guardian or caregiver of the adolescent patient, to help them understand what the authorized representative is and how that can support their care and how it works and why it might be useful to have it activated. So just coming back to this table of contents again, it walks through, the manual will walk through all of the steps for how to activate this, and just kind of be probably a refresher for a lot of you, but maybe some updates on things that have evolved with the feature, and help you think about incorporating it into your workflow even more if you haven't already done that. So that's our update on Medent user group materials, and that will be on the AHP website coming out in the next few weeks, and you'll be seeing communication about that from our AHP team. I'm going to go through my next topic, and then if there's any questions, I think we'll have some time at the end. Unless LJ, there was anything you wanted to say about this topic right now.
No, I'm good unless there's any questions
Okay.
from the team. No, we're good.
Okay. So the next topic I have is on a practice survey that we'll be sending out to learn a bit more from you all about how you're thinking about your current approach to patient-reported demographic data collection. So this work is aligned with our commitment to working toward health equity. The PRDDC, as we've been lovingly calling it, because it's a very long name, is focused on improving the collection of patient-reported demographic data in non-EPIC practices. We just specify that because the university has the HEART program, which is the Health Equity and Anti-Racism Technology program, where they're doing a lot of this similar work. So we're kind of mirroring and in communication with them about what they've done, and so that we can all be aligned in our approaches and best practices. So when we talk about patient-reported demographic data collection, the primary categories of interest are race, ethnicity, primary language, sexual orientation, and gender identity. One of the big things that we've been working on learning more about is the unique challenges for sexual orientation and gender identity information collection and documentation. So we know that there's a lot of times that can be documented in different areas of the chart, and is often collected in a different way than the race and ethnicity information. So just we're aware of that, and we're also aware that there may be and probably are some privacy concerns for the sexual orientation and gender identity data. So those are all things we're keeping in mind and hoping to learn more about and what you all experience in your practices. So the first step that we're taking here is going to be a survey that will be going out to non-EPIC practices to better understand your current approach. And we have been working with Pathway Pediatrics at Trillium to help inform, our collection of best practices. They've spent a lot of time thinking about and working on this because they're, for their annual reporting, and they've helped us, kind of review the survey and given us some feedback on that as well. And so as we move forward with this project and learn about what the needs and interests are, we want to focus on sharing workflow and documentation best practices. And on, one thing that we're already working on is validating that the data is moving appropriately across the systems, like from the EMR to Arcadia, so that we can access the information, and making sure, that your teams are able to use the information as well. So ultimately, we're hoping that higher or increased confidence in our patient-reported demographic data will allow for a better understanding of disparities and differences across groups and inform our health equity activities that hopefully will improve care across groups. So again, the survey should be coming out in early October over the next few weeks. And so keep an eye out for communication from our team about that. That is all of my information. Does anyone have any questions?
Karina, I didn't know if you had, I'm good at putting people on the spot, sorry team, but I didn't know if you had any comments you wanted to share since you've been working with the team.
No, I think it's going to be really helpful to get all of your input and how you get this data, because I think we all do this differently. And with the advent of the CARES Act, we all have data that we're collecting that we probably aren't comfortable putting in notes or putting in places in the chart. And so there's a lot of lost data that we probably need to see where we need to bridge gaps. And so seeing how other people do this in their practices would be helpful.
Thank you, Karina. Any other questions?
LJ, can I just take a moment to thank Karina and her team
Yes.
in sort of another wonderful engagement. It's been so appreciated, the work that all of you do and the engagement we get from this community. And Karina and her team have been really lovely in like helping us define kind of what we want to be doing in this space, approaching it really respectfully, making sure we're asking the right questions. And so I really appreciate all the work that you've put in. It's been lovely.
Thank you so much.
All right, perfect. I'm pausing for 1 second because I want to be sure. And I'm actually looking at Elizabeth, but she doesn't know that. Elizabeth, was there something else you wanted to give a very brief update on that I didn't allow time for, or you good?
I mean, yeah, we could.
up to you.
I'm looking at Kate, but she doesn't know it. So I'm gonna jump in here. Kate, feel free to jump in as well. But in the interest of like, I feel like this is my team show, and also the, hey guys, we're working on a lot of stuff. Please don't be overwhelmed. All of this is things that we want to hear from you on. We want to engage you on. We are also very cognizant that, like, especially this week, I literally saw one of my neighbors going for a walk. She's like, yeah, my kids were out of school Monday and Tuesday this week. We started on Thursday last week. So like, I imagine your offices are quite busy dealing with that. But one other thing that we are continuing to work on, depression screen and follow-up, is very much a priority for AHP. As you saw earlier in this meeting, it's a large portion of the provider incentive plan. And so I know that Kate is reaching out to touch base with practices about where they are, where things sit, and also ensure that we're getting credit for the follow-up. The documentation is a little tricky there to be able to capture. We are using the HEDIS definitions, and quite frankly, some of the qualifications, like that you need a follow-up appointment with a behavioral health specialist within 30 days for it to count. Nobody's getting in 30 days, right? It's 6 weeks. And so you could be doing everything right clinically and supporting your patient and not get credit. So we have a couple of ideas that we have piloted at various practices, and we'll be reaching out to see what might be a good fit at your practice if there's interest. Things like a plan of care for documentation, ensuring, that learning a little bit more about what you all are doing currently, and just making sure that that data is flowing. We want to make sure everybody's getting credit. Okay, I just stole the words from you. Do you okay, I'm getting a thumbs up, guys.
Yeah, you did a great
That
job.
wasn't on the agenda. Oh, thanks.
Thank you.
I'm also impressed with this team because I looked at the agenda and I was like, nope, nothing else on here because I'm not keeping these people past 8:30, but we are cruising, which will give us some time for the next 2 items on the agenda, and then maybe a little open discussion of any topics that you'd like to bring forward. So the next 2 things I'm leading on the agenda, and the first is just to really honestly is to talk about I knew I was going to mess it up. I can say it like half the time, then I can't. Nursimavad, which I don't know how we could possibly not have created a more difficult word to say, but I can imagine that you all heard the news of the approval with excitement and then extraordinary trepidation, and thinking about how in the world are we going to do this this fall. And so if I'm repeating to those of you who were on the noon call today, I apologize, but there's a lot of faces and a lot of names that weren't on that call. So I gave a brief update about what's been happening sort of at the system level, and just wanted to bring that forward to you and then hear your thoughts and comments. I think that every single one of us recognized immediately that this would require a smart population health regional rollout, and that having as much consistency as possible, since the ideal recommended administration for newborns is to happen in the first week of life. We really need for it to happen, if at all possible, at the birthing hospital before the child is born. That does not eliminate the need for this to be administered to older infants, and certainly to infants over 8 months who have significant risk factors for severe impact from RSV in their second RSV season, when you look at all of the recommendations. But just thinking about the sheer number of babies in Monroe County, our birth cohort now is somewhere around 7,500 births per year. And so you're looking at like a quarter of those in RSV season, right? That's a lot. And yet, and it wouldn't be efficient to be thinking we'd be actually capturing those kids in practices in the first week of life. So first piece of good news is that all of the regional birthing hospitals have come together with pharmacy, with administration, with our ID teams. Tim Stevens has been leading this, and we had great representation at a first meeting from Carolyn Cleary, from Kathleen Wania, and Dave Topo was on that as well, to be able to speak to the concerns that primary care teams would have, and especially because of the cost of this, which is thought to be around $500 per dose. So yeah, you just hear that and you think, oh my gosh. Now we also recognize that close to 60% of newborns are on Medicaid or do not have insurance and would qualify for vaccine for children. And so since this, even though it's not a vaccine, this is being described and rolled out as a vaccine. And so the majority of our birthing hospitals, not just in our region, but across the country, do not participate in vaccines for children. They don't necessarily need to. In New York State, there's a special provision for hospitals to administer the Hep B vaccine, as you know, in the newborn period, but they don't have to enroll in VFC for that. They just get that vaccine. But you can imagine that Hep B costs a heck of a lot less than this does. So everybody's concerned about cost, everybody's concerned about rollout. And there still is not an absolute definitive plan, but what I can tell you, we heard Susie Mullen repeat this today at the State of the Department grand rounds, as she represented Rochester Regional and runs the nursery there, that all of the nursery teams and the NICUs are working together to figure out how this will happen. And the Goldstone Children's Hospital and UR Medicine and Rochester Regional hospital systems are all looking at that as well. And this would include our hospitals that your FF Thompson and other birthing hospitals in our region. So we don't know exactly what that will be like. We don't know exactly when the vaccine will be available. We don't know exactly how quick the rollout will be from VFC. So you can imagine, I think it's going to be tough for us to catch all kids this fall, but I think they're going to try to do as many as would qualify and build a system that then will work going forward. But here's the key question that I have for all of you that still does leave these other infants who should be able to receive this medication. And I'm first asking if you're willing to participate in a survey in the next week or two to find out if your practice would be able to order and administer, and what the barriers would be. I mean, some of it's self-evident to me in terms of cost. And even though we have been told that the major insurers anyway, Excellus has said this will be covered, a covered benefit, but we don't know what they're going to be paying for counseling administration fees. And we do know that the AAP is lobbying for a new administration CPT code that would compensate better, similar to how there was a separate code for COVID vaccine and a higher administrative rate. So I'm hearing you, Carol. That's why, I mean, I think that all of us spoke up and said that, and everyone, as much as we want to see kids get this vaccine, the cost, well, I call it a vaccine, it's not a vaccine, but as much as we want to see kids get this, that cost is incredibly prohibitive. So Golisano Children's Hospital is trying to consider what kind of ramp up could be required for them to do a centralized effort like they did for COVID vaccine in the early COVID vaccine rollout. So I'm just curious what you think. So you're all throwing things in the chat and I can't keep up because I can't read and talk at the same time, but I'm going to look at the chat, and if you want to unmute and talk, please do, because this is really important. We need to really think this through and do it well. We don't want to create disparities or inequities. So I'm looking at what you've said. I'll read that, but cut me off if anybody wants to add in. Yes, cost is prohibitive for private practice. RSV Excellus still won't tell us reimbursement amount. You know, there is messaging from Excellus that they will in fact reimburse. We have heard that, but what they will reimburse you, to your point, is really key. So we don't have that level of detail. And I think that without knowing that, it'd be very difficult for any practice. I agree with you, Doug, to consider purchasing something like this. The other thing I will just add, maybe it's already in there, but we worry a great deal about storage and what that would do for your storage for other vaccines if you needed to purchase any kind of significant amount. Difficulty with cash flow, totally agree. Toby, thank you for your comment on that. I think we would need to think again about like what would happen in our communities outside of the immediate catchment area of the Children's Hospital. I don't know who's on iPhone. Who's on iPhone? Because they're asking lots of good questions, but I'm not sure who they are. Willing to share? I hate to refer to you as iPhone. So iPhone.
You beat me to it, LJ, because I was going to ask to say, if you haven't already, please let me know who you are. Because I was thinking, oh, it's Mary Beth. There we go.
Oh,
thank you.
Mary Beth. I won't call you iPhone. Yes. I should have known it was you, Mary Beth. It's very good questions. Yeah. This will be something that will be ongoing. Yes. For the children who are not able to get it in that window of time. But again, at the cost, unless there's a really clear until we know what the reimbursement will be, and until we know that VFC in particular has a well-established flow, I think it still puts practices at risk. Kathleen, you summed it up. I don't think our practices can afford to lose money on one more thing. So let me turn this around and say, would you find it valuable for your patients if there was some centralized vaccine, some centralized administration? I'm seeing head nods. Because I think Carolyn and Kathleen and Dave Topa, and I can take that back to the teams. There's a meeting next week. Definitely. Okay. All right. Great. Somehow this is reminding me of a game my kids used to play where we had to, like, I don't know, what is it? It's not quite charades, but like I'm reading and I'm done. So if anybody wants to unmute and use your voice, I love that. But no, this is really valuable information. And you still may end up getting a very brief survey because I think we really will need to quantify, so there may be something about newborns, number of newborns to your practice. Pharmacies will not supply this. I'm looking at where is Bob Adams, but Bob, like you're not hearing that pharmacies are going to supply this at all. I've been told no way. In fact, I think that was a direct quote from one of our pharmacies with a family name. Yeah, no. So we have to have a different setup. Not even with the prescription, Doug, is what we heard. That question was asked on a couple of occasions. I do feel like I'm playing a game with Doug. My God. Yes, I agree. It's ridiculous. So you're okay with being surveyed? If we need to, I will pay it really, we'll do it with your practice administrators. We'll make it like really, really quick, but I think we're going to need to plan. So thank you for that. We are going to send, sorry.
Can I ask that, since what we'd like to do is send it to you. And just because we send it to your practice manager, they weren't in the meeting. They don't know the ask. They don't know you're okay with participating. So if it's all right, LJ, and you don't have to see an objection to it, and if it's all right with the folks on the call, I'd like to send it to the members of the committee rather than the practice manager. I just think, you'll know what we're talking about, and we know we'll get a response if that's okay.
Yes. Yeah. Great idea. If people are okay with that. Great. That is what we will do. Thank you very much for that. And
hey,
I think
LJ.
Yes, Mary Beth.
It's Mary Beth. Can I just ask a somewhat related question of the group? We just looked at ordering our COVID vaccine today, and the baby COVID vaccine comes in a 3-dose vial, and we have to pay for each dose, and you have to give it within 12 hours of opening it. And we're thinking, if 3 babies don't accept it in one day, we're going to throw away 2 doses we paid for. How are people thinking about affording that?
So Mary Beth, that was the next thing I was going to bring up, and I'm grateful because it was coming up in the chat too. I think other practices are saying, can we talk about COVID vaccine? And this is a real concern. Doug, I know I've heard about this from you.
Somebody just commented that Moderna does come in a single dose.
Yeah, so Mary Beth, what we're doing Moderna for private patients, so we can order 10 doses at a time, and they'll hopefully supply quick enough, and we'll have to do Pfizer through VFC. And if we waste doses, it's at least the VFC, and it's not as a bigger issue. And hopefully that they'll be able to come out with Moderna as well. I mean, that's what we're doing at Ironic for Pediatrics for now.
Okay. It's a little hard to integrate the Moderna and the Pfizer because of the different ages. There's different.
We're gonna have to play a game. You're gonna have to mix in. I mean, they don't mix. You don't mix and match for the first doses, but we're gonna have to figure stuff out to make it work.
Only treat triplets. I like that one.
Let's see. Carolyn was unmuting.
No, I was going to ask Doug if they've said definitively if you got first, like at under 5, if you got a Pfizer, can you now get a Moderna? Are they mix and match for that age group? Because we weren't 100% sure. And then if you were going to do Pfizer, I think to Mary Beth's point, we were talking moving to Netherlands as an option. No, we were talking about like basically surveying people ahead of time and committing them to the dose. So not giving it on the spot the way we usually would with any vaccine, but saying like, I'm sorry, you're going to have to commit ahead of time and we'll line up 3 patients, that kind of thing.
I know it's with the first round, you have to stick with it. I'm assuming you have to stick with the same brand. But if they've already finished the primary series of either Moderna or Pfizer, I think you can boost with either or. So I don't think you have to stick with the same brand for that. But if you're doing if they're unimmunized or never immunized, I think you do, to boost them up, you have to stick with the same brand. That they haven't come out with any recommendations. So everyone 6 months and older can get the vaccine, but they haven't said, what about the unimmunized people? Can they get one dose and done? I haven't heard that yet. I think that's where we're stuck waiting.
That came out today. They need multiple doses.
Any other comments?
We're trying to figure out in terms of ordering in our office. So with the VFC and New York State, like they had a webinar last week. Obviously for VFC, you need to offer all ACIP recommended vaccination. But the question that our office has is, does that mean that we need to offer Moderna and Pfizer and Novavax? So we have to order all three, or just offer a COVID vaccine of some sort for every age group? I'm seeing a nod, so that makes me a lot happier.
believe
Because I
it's
thought I was gonna have to order 6
yeah,
vaccines.
not all.
Yeah.
Is
not all.
anybody? Yeah, okay.
Not all.
Agrees. Okay. Is it, I mean, you all are in the middle of this right now and are clearly investigating this. Is there anything that you would like you need from our end at AHP to just try to provide some clarification, some kind of a summary like we've done for some other things? Is that useful to you, or do you feel like that'd be good? So I'm just I'm thinking Bob Adams maybe. Is that okay, Bob?
Absolutely. I was taking notes for thinking the same thing.
Okay, all right. Let us put something together, run it past a few of you who've been like right in the thick of this too, and just make sure we're passing on the best information possible to our practice teams. Okay. Jen Lessick, I can answer that office question. I'm wondering if people are still making patients wait for 15 minutes after giving vaccine. We have understood that if it's booster doses, there is absolutely no need. They are not being required to wait in other places unless you had a child who had some type of a reaction, the last time around. Otherwise, no. And Carol, I've heard this from a couple of other practices about only keeping COVID vaccine available in your practice for the 6 month to 4-year-old age group, and everyone else goes to the pharmacy. It is sad to me that, because I think the primary care practice is the best place, to receive. But at this point in time, I think people have got to do what they got to do to keep this as efficient as possible. And where there's other resources that can be tapped, similar to Doug's question about, is Befortis going to be given with a prescription at a pharmacy? I think we have to utilize all resources to keep things moving in your offices. Okay. Jen just added for the primary series. Jen, I'm going to let one of the other providers on the call. Are you waiting 15 minutes, gang, for your primary series vaccination after vaccination? I'm not seeing head nods, head shakes.
Should we be? We should be. I don't think I'm remembering to do everybody, but we should be.
My understanding was for the primary series was that's what people were trying to do anyway. Okay, what other questions are coming up here? What am I missing?
Just one more about needing our consents needed for the booster as well.
I'm seeing some head shakes, some no. Informed consent, but not signed consent is my sense is, conversation, education, but not signed consent. Okay. Great. Okay. So we have our task to work on. Please keep us posted with other things, and thank you for bringing that forward. Our last topic for this evening is really to just highlight for you all that we do have an October AHP clinical grand rounds. As much as we had kind of hoped to do one of these in person again, we are opting for a virtual meeting at this time because it does allow for so many of our providers who are working with us from a greater distance to participate. And it does give us a nice opportunity to do what we did last time. We're going to start with the group together, all providers across AHP. You will have the opportunity to meet our new executive medical director Angelique Cohen, who starts October 1st. She'll be speaking at that event. You will also have an opportunity to hear from some of our behavioral health experts. We've been asked for a brief overview on ADHD in young adults and adults. It's been asked for by our adult care providers and from many of you in pediatrics as well. So some of our behavioral health experts will be talking about that briefly. This will be one of those grand rounds again, that's sort of like the small feedings. It's not going to be a super long topic, but trying to capture a couple of things. And after that introductory period, we're going to split. And the peds, anybody who wants to hear about child-related stuff is going to come into the Zoom room with me. And then anybody who wants to hear about the adult stuff is going to go into the Zoom room facilitated by Angelique. And so for our end, for the pediatric end, I'm going to let Bob Adams talk for just a second to give a highlight, but we're looking to introduce to you all smart therapy for asthma. And this is sort of an introduction piece that then can lead into a nice practice visit. We've trialed a couple of these. So Bob, do you want to talk about that?
Sure, yeah. I'll be teaming up with my partner, Paul Tremblay, a nurse who's been working a long time with Jill Halterman in the asthma space. And we're going to kind of go over some of the guidelines that really kind of started off in 2020. And we know there's a lot going on in 2020. So some of these guidelines may have been missed. As long with, besides talk about smart therapy, we're going to talk about some of the new assessments that are available to kind of simplify, the check-in with your asthma patients.
Thanks, Bob. So that's one of our topics. And then I'm really looking to you all to inform whatever else we cover. In the adult space, they're looking at things having to do with, oh my gosh, I'm going to have a blank right now. It's about workup of kidney stones and management of kidney stuff, which was not very technical or medical sounding or professional sounding, but you get the idea. The idea is to have something you can walk away from this session and be like, oh, that's something new that I wanted to know. That's a resource I can use. We want it to be very tangible and valuable to you. So I will tell you that various specialists over at Gallstone Children's have said, I'd love to come in if the primary care pediatricians have interest in any particular topic areas. So that's what I'm looking for. What would you like us to set up for our part of the session? So this would be a second complementary topic or a second complementary speaker who could cover a few different topics. Anything you're dying to hear about, learn about, wish you had access to?
Obesity.
Obesity.
The new obesity guidelines.
Okay.
I agree.
We've been struggling with.
I agree with Carolyn.
Okay.
Especially talking about semaglutide therapy.
Yep. Great. And I'm sorry, I couldn't see who else was unmuting and talking at the same time.
It's Karina. Our team has been getting a lot of questions from families about like chronic pharyngitis and when to get a TNA as they're older. And then not with it actually, like sleep apnea questions, who to go to, ENT versus sleep, how to get in, all that stuff.
Okay. I'm going to keep a running list of this conversation, and we'll get some of this, but then we'll use this for other things, and we can even use this at times for one of these meetings if you want to do some clinical stuff in one of these meetings. Other things?
LJ, I just put it in the chat, but if you're going to talk about obesity and the guidelines, Medicaid just dropped covering all those drugs. So all the children on Medicaid no longer can get those medications.
Toby had put in the chat. Project Teach, psychiatrist talking about diagnosis and treatments. The Project Teach team is also doing, so a lot of, I think the group here, I think has participated in Project Teach at different times over the years in their big trainings and also their smaller practice trainings, but they're doing is a lot more Zoom trainings, smaller segments, Toby. So we are actually pulling together some information for another practice that was interested in doing some work with them. And so we'll share that out So we may not use that for this forum, but we'll definitely share that information out because they are looking to be available for practice teams. Anything else? Anybody got any burning surgical questions? I'm only asking because Marge Arca, our chief pediatric surgeon, said, I would love to get to know the primary care pediatric teams better. And I wonder if there's anything they would like. So I'm just asking.
There may be new things in appendicitis about like rushing to treatment, not treatments, you know, antibiotics, conservative management. So
perfect. And again,
One thing that,
go ahead, Toby.
sorry, one thing that comes to mind is trying to figure out who to send a kid with a really weird pectus and scoliosis to. Because the scoliosis guy said, well, we don't do rib. And the rib guy said, well, we don't do that. So it was like, okay. So some insight on that would be nice.
Great.
I've had a lot of questions recently. I think it's on TikTok about Ehlers-Danlos. And Room doesn't do that, and Neuro doesn't do that. So then you get genetics, and they want everything, and everyone thinks they have it.
it was a TikTok surge.
Okay. These are great. Excellent. All right. And let me work on this and we'll pull in at least one of those, or if they're shorter, we'll pull in two, and then we can use some of our time in our future evening sessions, potentially to bring in an expert in. I think it is a nice way to just have collaboration and education with our specialty teams. All right. You all have been incredibly helpful. Thank you for the rich conversation.
Don't do it yet, LJ.
I'm not closing it yet. I'm not closing it yet. Don't worry. I just want to say I'm looking in this chat and I'm like, holy cow, this is one of the longest meeting chats I've ever seen. So I just want to thank you for your help with that conversation. And I didn't say when the AHP clinical grand rounds was. It is October 25th from 5:30 to 7 p.m. Okay, we got that. Now I'm turning over to Jana.
The only thing I want to say is I'm pretty sure I've captured everyone who's in attendance tonight, but if for some reason you have not added your name and you are not Mary Beth, who we know is the iPhone user, please enter your name into the chat so that we can get you your credit for attending tonight. That's it. That's all I wanted to say.
Thank you, Jana. Any last words from anyone else on the call? Giving you 3 minutes of your life back. Thank you very much. You are really an amazing group of people, and we are like really lucky to support your work and to work with you. So thank you. And again, Renee, you just like take all those words and soak them up. Okay. All right. Awesome. Soak them up. All right. Have a good night, everybody. And thank you.